Great. Well, welcome to Medical Grand Rounds. We're delighted to have first I'm going to welcome Dr. Suzanne Norby, who is our new Division Chief of Nephrology, and we're delighted to have her join the department. And I will have Dr. Norby introduce our special guest speaker today.
Thank you, Dr. Schnapp. So today we have with us Dr. Jay Koyner, who's from the University of Chicago. We'll talk about a little of his background. He got his medical degree at the State University of New York in Stony Brook, where he also did a Howard Hughes Medical Institute fellowship, followed by his internal medicine residency and fellowship in nephrology, both the clinical and research fellowships at University of Chicago, where he's now a professor of medicine and also the director of the inpatient dialysis unit. So Dr. Koyner is really a leader in nephrology nationally. He does a lot of work with multiple specialty societies, particularly the American Society of Nephrology, where he is a member of the AKI now, Acute Kidney Injury Artificial Intelligence Committee, the Excellence in Patient Care Committee, and also chairs the Augmented Intelligence and Digital Health Committee. He's very involved in research. He has over 150 peer-reviewed publications, and his interests really are in biomarkers for acute kidney injury, kind of detection, mitigation, and prevention, along with prognosis and management. So it's really a treat to have Dr. Koyner with us today. Thank you for joining us, and look forward to your talk.
Thank you. Thank you for the kind introduction. I'm super excited to be the homecoming speaker. It's a big honor. Right, you can see this slide. I have multiple disclosures that you'll see in the next couple of slides. Here we go, right? So here are my financial disclosures. To be honest with you, some of them are relevant, some of them are not. I do like to barbecue. I was at the National Kidney Foundation meeting earlier this spring, and people came up to me, say, "You're the barbecue guy." And I was sort of excited, but also a little bit disappointed that they didn't want to acknowledge some of the other work that I had done, but so be it. From my perspective, I generally like to start medical grand rounds with a case. The details aren't as super important as you might think, but this is a 54-year-old guy. It's an actual case from a patient that we enrolled in one of the studies that you'll see later, who has a known history of chronic pancreatitis. He was on the floor for several days or on the hospital ward for several days, and eventually he began to get worse. His enzymes, his pancreatic enzymes began to get worse. He continued to have respiratory failure. He failed non-invasive ventilation, began to develop an ARDS type picture with generally low mean arterial pressures, continued to get fluid. His urine output was marginal, and his creatinine was going from 1 to 1.4. And the question that most nephrologists I think might be interested in is, where is he going to be tomorrow? Do we actually need to see him? And then what do we need to do to try to get him better? And these are some of the questions that we're going to answer over the course of the lecture. I say that knowing that this is the way many people think about nephrology, AKI, and the kidney. Maybe it'll be a little bit better after the talk. Maybe it won't. It depends how good a job I do, right? This is a brief outline of what we're going to talk about. We're going to start by defining the problem to make sure that we're level setting and everyone knows what we're talking about when we talk about AKI. We're going to talk about biomarkers. And as Dr. Norby said, I do a decent amount of work around novel biomarkers. I'm not really going to be focusing on the things that you don't have here at the University of Wisconsin, because there are lots of biomarkers that are here that I think are probably underutilized. I'm then going to transition to talk about electronic medical record risk reporting and some work that I do with Matt Sherpak, who's here in the audience. And then we're going to close by talking about the care of patients with AKI, right? And this is a super complicated plot that describes AKI. Very rarely, at least in our hospital, and I imagine in yours, is the AKI single factor driven, by which I mean, hey, we just gave this person gentamicin. Well, why'd you give them gentamicin? They had sepsis. Maybe they were on a vent. Maybe they've got CKD, and that there are usually multiple things that go into any case of AKI before it happens. And that perhaps is why I find it so interesting, and maybe why it's so tricky for us to do a good job taking care of patients with AKI. This is the consensus definition of AKI. It is a 3-stage definition that has been agreed upon now pretty much for the last 10 years. But what I like to highlight is the idea that 20 years ago, when I started doing this work, there was no consensus definition. that if you go back and look at things like the original ARDS-net paper, they defined AKI as a creatinine greater than 2. So you could come in with that creatinine greater than 2, you could develop it during the hospital, it didn't make a difference, it was all AKI. And the idea now is we know that changes in serum creatinine and changes in urine output, whether over 6 hours, 12 hours, 24 hours for the urine output, or increases in the creatinine over time correlate with adverse outcomes, whether we talk about things like needing dialysis, longer stays, or more cost of care. This is just a visual abstract. I'm actually not a super big fan of visual abstracts, but it highlights to me the idea that we're not doing a good job taking care of patients with AKI. What I'll highlight for you is that you can see the decline in hospital-associated adjusted mortality, 0.994, so less than 1% improvement over time in data taken from the VA system over a nearly 20-year period. So that over 20 years, we've moved the mortality by less than 1%. So there's a lot of work to do from my perspective, right? And just as I highlighted before, so mortality hasn't changed, cost of care has increased, hospital time in terms of length of stay has increased, mortality in some places has even maybe unfortunately increased. It depends on how you want to look at it. And more importantly, if you develop your AKI while you're in the hospital versus develop it at home and then come in, that carries a different mortality as well. And from my perspective, there's just a lot of work to do. And that AKI is associated with lots of things that you don't want to have happen to your patients, and we can probably do a better job of caring for you. I think it's also important to level set the idea that AKI is probably part of a spectrum. I'm not going to delve too deep into AKD, but I think most of you are familiar with CKD and the idea that when we look at this AKI definitions that I showed you before, they take place over 7 days, and something needs to be happening between 7 days and 90 days because it takes 90 days to develop CKD, and that's what this idea of AKD is. But the larger point here is that AKI occurs as part of a spectrum of kidney disease, and that, as we'll talk about in some of the later aspects of the talk, AKI oftentimes unfortunately begets CKD and is a tremendous risk factor for it. Right? So the markers that we have for AKI are serum creatinine and urine output. Neither one of them are perfect, as we'll talk about in the next few slides. Creatinine certainly isn't sensitive, right? There's lots of tubular injury, as you can see here, that doesn't actually affect creatinines. People will donate a kidney or even have a large portion of a single kidney removed, and it won't really change their creatinine. I'm sure that most of you are familiar with the idea of pre-renal azotemia and people who will have increases in their creatinine, and then despite looking in their urine or looking for other markers of kidney injury, we don't see anything. We hydrate them, reestablish their intravascular volume, and they get better. Similarly, creatinine is often delayed. We know sometimes maybe post-operatively, patients have been exposed to increased AKI risk and their creatinine won't actually bump for 24 to 48 to 72 hours afterwards. And then lastly, the things we do to patients, like giving them tons of fluids, can actually falsely lower their creatinines. And similarly, if you volume restrict someone or don't give them the hydration that they need, they can actually have that pre-renal azotemia that we talked about before. That said, you need to be checking creatinines in order to find AKI. I think it's important to acknowledge that at least in our own hospital, and this is data from a paper that I'll circle back to later, we demonstrated that nearly 14% of people who are admitted to the hospital don't have a creatinine checked. Internally at U of C, we've actually made some efforts to try to change some of that in some of the high-risk patients. Through some of the work that we did with Matt, we determined that there were a large number of people going for joint replacements, getting tons of NSAIDs on our ortho service who were never having their creatinines checked, and then were being readmitted. And we realized, hey, maybe we should start checking some of those to prevent some problems. That said, I suspect that there are a lot of patients in your own hospital who come through for 24-hour admissions, or however we call them, 23-hour admissions, and don't get their creatinine checked. You need to be checking creatinine in part to find AKI. Similarly, urine output is not a perfect marker either. I think that if anyone understands urine output, I'd really love to talk to them about it, because low urine output can be entirely appropriate or it can be entirely inappropriate. And We don't have a great way of figuring out why that's the case. I'm sure that your heart failure and your liver services are currently filled with lots of people who are not making all the urine they should be, even sometimes on diuretics, and we don't understand why, versus folks who have oliguria and it's entirely appropriate because they're maybe about to bleed into their hemithorax or they're already having volume losses elsewhere. A great example about that would be maybe folks in our burn unit, right? When people think about AKI, I think they traditionally think about it in this context. I know that 25 years ago, this is the way I was taught: pre-renal, intrarenal, post-renal. And this comes from a New England Journal article that I actually remember my nephrology attending handing out when I was a third-year medical student. I actually hate this way of thinking about AKI. And I'm a big believer that we need to try to think beyond this, because pre-renal means so many different things to different people. For some people, it's a physiologic state. In this plot here, it's clearly before the kidney, right? Before the kidney, in the kidney, after the kidney. I prefer to think about AKI in terms of this, and it's a little bit messy, but thinking about, is there evidence of functional change? And that's what creatinine and urine output are. They're functional markers of the kidney, versus is there evidence of damage or other injury markers? And we'll be talking about some of those in the next few slides. And then you can see, if you don't have functional or damage changes, you're making great yellow urine like here. If you've got changes in both, you probably don't need a fancy biomarker, because we know that from the creatinine and the urine output. It's these folks on the margins, the folks who have a loss of function without damage. Those are the, in quotes, pre-renal folks. And these folks in brown who have evidence of damage without really any loss of function. The easiest examples there are folks like I talked about before, folks who maybe donate a kidney, but also have their kidneys cross-clamped. People may not want to hear it. A great example of this is folks who run marathons. When you collect the urine from folks after they're done with a marathon, their urine is filled with injury markers, but their creatinine is stable. It's one of the many reasons I don't run marathons, right? So when we think about the markers that we have, right, when I started with this work 20 or so years ago, it was to sort of find the renal troponin. Our cardiologists and other colleagues have done a great job of improving on things over time, and we're still sort of stuck with serum creatinine. I think we're moving, as you'll see at the end of the talk, towards better markers. I also say to you the idea that there are many different forms of kidney injury, and we diagnose them all with creatinine, and that seems crazy to me. I have a decent amount of work that we're doing on phenotyping that involves some of these novel biomarkers that I think are beyond the scope of what a medicine audience might be interested in. But I think that this slide for me always hits home, because there's so many different forms. And I think everyone could agree that hepatorenal syndrome is entirely different than cisplatin-induced kidney disease, which is different than cardiorenal syndrome, but we rely on the same two crummy markers to define it all. And you'll see how some of the risk score work that we're doing actually may do that. And we're gonna now move into talking about urinalysis. Last night, I adjusted this slide after I heard about Phil the Hill from the local news folks. So thanks for laughing. Right? So we're going to talk about urine electrolytes and urinalysis. I also learned last night, and I was ecstatic to hear that the nephrologists here spin their own urine, both in clinic and on the floor, in clinic and on ward patients. And I think that that's super important. I think that urinalysis is a very underused tool. And what I have up here are 3 different scoring systems that have been published from Mink Chawla from when he was at GW, Mark Parazella from when he was at Yale, or he is at Yale, and then Sean Bagshaw from Alberta. You can see that they all involve counting the number of casts, counting the number of renal tubular epithelial cells. They assign different scoring systems. If I'm honest with you, I don't use any of them. Clinically, it's sort of, hey, are they there, or are they not there? But over and over again, they've been demonstrated to be useful, by which I mean, if your patient has more renal tubular epithelial cells or more muddy brown casts, you know that they're unfortunately maybe destined for dialysis. In some studies, they're destined to definitely meet a nephrologist, more likely to have morbidity and mortality in the hospital. And so that it's really useful to do as a prognostic tool. And something that, as we talk about, I think you need to become proficient in, not just as a nephrologist, but I also heard last night that just like at U of C, when the residents rotate with nephrology, they learn to do it and then they do it on their own. And it's something that if you can't just do it every once in a while, you need to sort of continue to identify those things, not because there's more to urinalyses than just muddy brown casts and renal tubular epithelial cells. This is a study from the Mayo Clinic where they looked at patients in the emergency room who had UAs and identified the idea that the things that you can see in the urine, whether it is renal tubular epithelial cells or granular or muddy brown casts, are highly specific, but not all that sensitive. And the same thing is true for things when you start looking for other items in the urine not specific for AKI, and that's important in the sense that you can't just rely on them alone, but if they're there, that's certainly a bad sign for your patient. I think the other reason it becomes important to make sure that you're doing it repeatedly is this paper that came out in the middle of the pandemic. It's one of my favorite things I read. They sent pictures of urine to 14 senior nephrologists, 70-something pictures, and asked them, hey, what is that? And outside of the muddy brown casts and the renal tubular epithelial cells, not even for the renal tubular epithelial cells, they really couldn't agree, right? Muddy brown casts are this thing, at least that in my mind, all nephrologists should be able to identify. They only had agreement about 80% of the time. And then it was much worse when you start thinking about things like white blood cell casts, if you're concerned for pyelo, or red blood cell casts, if you think your patient has a GN. So it really takes expertise to do it, and you can't just do it every once in a while. I do think that one of the reasons that you need to do it more and more is that this data, which also came out during the pandemic, that demonstrates at least in our hospital before this came out, we very rarely looked at urine more than once in the same patient. If you go back and look again, you can find more patients who have more kidney injury, and it correlates better with their outcomes. So that they went back, this is data from the Ochsner Hospital down in New Orleans from Juan Carlos Velez and his group, where they went back on day 2 and day 3 and day 4 and day 5 and looked at patients' urines, and they were able to unearth patients whose creatinines were maybe not moving in the right direction yet, and they could see that they had ongoing injury. And so that using urinalysis multiple times in the same hospitalization has probably been shown in this study and others to be useful. And I think that it's a valuable tool that correlates with adverse patient outcomes. When we talk about AKI, I think most folks, as we transition to talk about urine electrolytes, think about things like the fractional excretion of sodium and fractional excretion of urea. I'm less enthusiastic, if I'm honest with you, about these things compared to urinalysis. I think most people are familiar with cutoffs of around 1 and 35, maybe for the fractional excretion of urea. When we talk about the fractional excretion of sodium, this is the original paper. I don't want to tell you what I was doing in 1978 when it first came out, but I was doing things in 1978 as opposed to maybe most of the people listening. But when Bob Schreier at Colorado sort of first described it, he described it in folks who had oliguria. They didn't have any CKD. They didn't have people on diuretics at that point in time. And they used, as you can see down here, they wound up with the same cutoffs of less than 1 and 1. We have universalized it without actually thinking about it. I'm confident that this morning, probably 8 to 10 patients in your hospital have the FeNA, and that all of them probably are making more than 500 cc's of urine, and most of them had CKD. And that when folks have worked to validate it, this is a picture of Pat Murray, who is I was gonna say former mentor, he's still my mentor. Never outgrow your mentors, who back when I was a fellow, we did a bunch of projects looking at some of the other biomarkers that you can see up here. And it's less about the fancy biomarkers, it's more about the idea that in these 2 studies where we looked at patients who had stage 1 AKI and measured the FeNA, the AUCs for the FeNA were around 0.5, meaning they were completely lousy at predicting who was going to get better versus who was going to get worse, with the idea being that if your FeNA is low, most people will say, hey, you're pre-renal, we're going to give you fluids, and we're going to improve your AKI and rehydrate your kidney, and you're going to get better. But over and over again, we have demonstrated this. This is data from a separate study that we did looking at 120-something cardiac surgery patients, where we looked at the FeNA and the FeUrea at baseline, at the time of their ICU arrival. Baseline is in the preoperative state, ICU arrival a couple hours after their ICU, and then their maximum and minimum, knowing that we had measured urine electrolytes 4 times in the first 48 hours after cardiac surgery. And you can see here a table of nothing but AUCs of under 0.5, none of which were statistically significant, whether you tried to predict stage 1 AKI, the eventual development of stage 1 AKI or stage 3 AKI. So the idea being that the fractional excretion of sodium, which is something that I think the average non-nephrologist uses all the time to prognosticate and diagnose AKI, is not really a great tool. And the same thing is unfortunately true for the fractional excretion of urea. I have a little bit of guilt about this because Orly Cohn, who was at the University of Chicago for about 35 years and taught me most of what I know about peritoneal dialysis, is on the original paper. But the same idea is true. It has not been validated, again, in patients prospectively, with the idea being that they looked at some of those same restrictions, patients not making a lot of urine, patients without CKD, to establish a cutoff of 30 to 35%. And it never has been truly validated, which you saw in the previous slide. I think most importantly, it's not just my own data that shows that it hasn't been validated. This is data again from Juan Carlos Velez and his group in New Orleans, where they demonstrated that the FINA actually doesn't correlate at all with the urine analysis findings, and that the muddy brown casts that we talked about before were more likely to predict who was going to go on to develop more severe AKI, whereas FINA and FE urea measurement were less useful. So to sort of summarize this point, I am a big believer in moving away from the FINA and the FE urea, remembering importantly that most diuretics, or almost all diuretics, work by telling the kidney to dump sodium. So that if your sodium is low, especially in someone who's getting diuretics, you have to sort of wonder why the kidney is working to conserve sodium. You need to, you can use the urine sodium independent of the fractional excretion of urea, or independent of the fractional excretion of sodium, but you have to understand the situations where the urine sodium can be low, whether that's diuretics, contrast, calcineurin agents, even in folks who have vascular congestion and right heart failure, whether that be patients with liver disease or patients with congestive heart failure or urinary obstruction. So there are lots of different areas where your urine sodium can be low, and it doesn't necessarily correlate with prerenal azotemia. You can actually have pretty decent tubular injury. Transitioning away from urine electrolytes, I'm going to talk a little bit about volume overload in AKI, remembering that in the early 2000s, I grew up in a medical era where we told patients, no, we want you to be swollen. That means that we're hydrating you and we're perfusing your kidneys, and you have to swell to get well. I have multiple attendings from U of C who use that phrase, both in nephrology and outside of nephrology. And I'm not sure that that is the right answer from my perspective. This is a little bit of a busy slide, and I apologize, but it goes to show the work that my friend and colleague Stu Goldstein has done in the pediatric AKI world. You're not supposed to be able to read all the little fine print, but you can see these are all the papers that the pediatricians have published that demonstrate that getting volume overloaded in the setting of AKI is a problem. And they define volume overload as being either 5 or 10% above your admission weight. So that if you're at a place like U of C where the average patient weighs 85 kilos, it means getting 8 or 9 liters positive. I'm pretty sure that on every service I've ever picked up, there are 2 or 3 patients that are 8 or 9 liters positive. I'm not sure whether or not you guys in Wisconsin have that same problem, but there's lots of fluid going around. And it gets easy to become volume overloaded. And in the setting of AKI, it's been shown over and over again that it leads to adverse outcomes. You're less likely to recover your kidney function. You're more likely to require dialysis. Drug dosing isn't always ideal when someone is volume expanded to that point. Drugs are often underdosed, and it takes longer for those drugs to actually get to where they need to go if you're so edematous. And you may be thinking to yourself, great, Jay, we're adults. We take care of adult doctors. The same thing is true in adults. This is data from the Picard study, which was a prospective observational study in 4 US intensive care units, where they demonstrated in over 600 patients the same idea, and that this risk of morbidity and mortality was true in all patients who had AKI, whether you required dialysis or didn't. The more volume overloaded you were, the more likely, unfortunately, in the setting of AKI and volume overload, you were to die. You may be thinking to yourself, I don't care. I'm not interested in percent overload. They demonstrated the same thing just from total body weight gain, just from using the bed scales or weighing the patients on a daily basis. In the setting of AKI, the more weight gain you have, the more likely you are, unfortunately, to die in the hospital and have other complications. And we've demonstrated the same thing in our own hospital. This is a picture of Sam Gunning, who is a trainee and now a junior faculty member. She has an interest in volume overload and works with me. And we looked at about 100 or so patients who were on ECMO in our hospital. We actually demonstrated that they were at greater risk for mortality if they were volume overloaded than compared to if they had AKI on ECMO. Of course, if you had both, as I told you before, it was a multiplicative effect with a hazard ratio above 8. But the idea being that volume overload is this other marker and this other problem that I'm sure, I assume you guys use Epic here, right? I guess I didn't ask, but Epic has multiple different ways to show you if a patient is volume overloaded on the eyes and nose. You can look at it from a table form to a bar graph. And I would hope that people are paying attention to it. But in the setting of AKI, volume overload is especially problematic. And I think it's unfortunately under-recognized to the point where whole other lectures could be given about the studies about when to initiate dialysis. None of them have ever accounted for the idea that patients who are volume overloaded as a trigger for dialysis. There are no studies in adults that say your patient is 5, 7.5, 10% volume overloaded. Let's start dialysis to try to prevent further mortality. And I think that you're going to see in the next 3 to 5 years some studies looking at exactly that because of the nature of the issues. Who doesn't love anthropomorphized ice cubes? That's what I want to know, right? So we're going to talk a little bit more about urine, my favorite body fluid. Talk a little bit about the furosemide stress test, which is another biomarker that I know that you guys have available to you because you have furosemide and you have patients who have AKI. It's early in the morning, so this is maybe the point in time where those of you who are not nephrologists want to doze off because I've got a picture of a nephron up here. But I want to remind everyone how furosemide works. It actually isn't filtered at the glomerulus. It actually makes its way in the nephron, in the proximal tubule, where it goes from the blood into the urine space through organic anion transporters, and then eventually it makes its way to the loop where it blocks the sodium potassium 2 chloride pump and keeps the sodium in the urine, like we talked about before. Right? This is a lovely picture from a review from C. Jason. So for the non-nephrologists, if you're suffering from insomnia, I highly recommend a paper on proximal tubule protein and transporters. But for those of us that are more interested in it, it becomes important because when we go back to the nephron, in giving someone furosemide, you need blood flow to the kidney for the furosemide to get there. You need your proximal tubule to be working. You then need the loop to be working in order for the signal to be blocked. And then you need everything else down the rest of the conveyor belt to be working as well for the diuretic to have an effect. So if you've got a patient who has AKI and you give them furosemide and they make urine, it's a good sign. It shows you that almost every part of the kidney is working in order to get a urinary response. And so what we did was take originally 70 patients who had stage 1 AKI, and we gave them a protocolized dose, it was on the prior slide, of 1 mg per kg or 1.5 mg per kg if you've seen a loop diuretic before, and said, we're going to measure your urine output after we give you this protocolized dose, and we'll see how much urine you're making. Right? And so we did that, and we demonstrated that patients who did better, or patients who made urine did better and were less likely to have their AKI to progress and less likely to require dialysis, less likely to die in the hospital, and seems like a good thing, right? We demonstrated that if you made 200 cc's in the first 2 hours, that it was 88% sensitive and 87% specific for non-progression. We then went on to do a multi-center study where we validated it and demonstrated almost identical AUCs. The same idea here, whether you talk about that second hour, the individual urine output or the cumulative, again, that if you make 200 cc's of urine in 2 hours after a timed furosemide dose, you're less likely to have your AKI progress. And that the folks who progressed versus those who didn't progress actually did better, right? It makes sense that if your AKI progresses, you're going to need dialysis, you're unfortunately at greater risk for death, you're going to be in the hospital for longer, you're going to have all the problems that we know are associated, unfortunately, with severe AKI, right? And we've actually taken it a step further and demonstrated that if you pair the furosemide stress test with some of those novel biomarkers that I've sort of alluded to before, that you can identify a patient group that is at super high risk for the development of AKI. And this is just borrowing from a paradigm from other aspects of medicine, the same way where we use functional versus damage biomarkers in cardiology or in looking for folks who've got pulmonary emboli to combine the two. And we demonstrated here that whether you want to talk about NGAL or TIM2 IGF-BP7, the details of the biomarkers, I think, for the purposes of this talk are less important, that patients who have elevated biomarkers and then fail their furosemide stress test do worse than those whose biomarkers are not elevated. And this is our own data from the original cohort. Others have demonstrated the same idea. This is data from Kent Doi, who's at the University of Tokyo, where they demonstrated that combining NGAL and the furosemide stress test identifies patients who are destined for dialysis, patients who are destined for severe AKI, destined, unfortunately, for all those adverse outcomes that we talked about. We actually have more data of our own where we have looked at this idea and not so much at the receipt of dialysis, but actually at patients who meet criteria for dialysis, because for many reasons, sometimes patients actually don't get dialysis just because their BUN is elevated or they have some amount of acidosis. Oftentimes, unfortunately, there are care limitations. And when we went back and looked at our original study, we found a handful of folks who probably should have gotten dialysis by the criteria, but because good care was being delivered or it wasn't part of their goals of care, they didn't get it. And it sent us a signal that, hey, maybe our data around the FST was actually even better than we thought it was. So we've gone back and looked at a new cohort of folks with Alex Zarbach, who is a colleague from Germany, where we've got data on folks. And then we're looking at, do they have a K greater than 6? Is their pH less than 7.2? Do they have a BUN that eventually rises to 140, but they're never going to get dialysis for it? And we demonstrated that pairing the FST with other biomarkers, sorry, this is cut off at the bottom, actually demonstrates that you can use those two together to identify folks who are at high risk for the most adverse outcomes, right? Hey, I know that smiley guy. He's sitting right there in the 4th row, right? So the FST is, and I want to be clear, I think that the FST is a test that I bet not just the nephrologists, everyone has used for a long time. It's just that we protocolized it and then demonstrated that it was associated with the outcomes that everyone had sort of already known. For decades, nephrologists and intensivists and hospitalists have been doing that on Friday afternoon. Let's give this guy or gal Lasix. Are they gonna get better or worse? Do we have to put a line in them? We now have the data that shows that that was actually a pretty good plan. We're going to transition to talk a little bit about the electronic medical record and electronic medical record risk prediction. It's data and work that I've done with Matt and our colleague Dana Edelson. Donna and I were interns together at U of C, and we shared bunk beds back when residents slept in the same room in bunk beds. Oh, we slept on top. That's because Donna was pregnant with her first kid during internship, right? So this is, I showed pictures of other colleagues. That's me back when I was happy and thin and had even fuller head of hair. And this is to highlight the idea that I did a lot of biomarker work looking at NGAL and KIM1 and other things. And we're not using those biomarkers sort of clinically because we didn't hit a home run. But back when I was happy and thin, I met Matt and Donna, and I was actually doing consults, and I got called to see a patient who was a lung transplant patient and had just been transferred to the ICU. And he had been transferred because his ECART score was high, and they were concerned, and they were piloting a project on 4 Northwest, which was the old transplant floor, that said, hey, if your ECART was high enough, which was this risk score that they had developed and published on, that demonstrated they could predict patients who were going to have in-hospital cardiac arrest or clinical deterioration. And so it was Friday, I did the consult, I was on call that weekend, and I set a reminder right then and there to email Matt and Donna on Monday to say, hey, if you've got a risk score that the hospital will implement for cardiac arrest and clinical deterioration, we should be able to predict AKI, because all it is a change in serum creatinine. I foolishly thought then all it is a change in urine output, not realizing how poorly urine output is actually recorded in our electronic medical record. And eventually, through some persistence, we published a paper, the original one in C. Jason in 2016, which was a regression model, which demonstrated, not surprisingly, that you could actually predict AKI quite readily. In fact, I remember you actually ran after we coded for AKI that ECART predicted AKI with about an AUC in the low 7s. And that was sort of enough to say, well, if we build a model specifically for AKI as opposed to one for clinical deterioration or cardiac arrest, we can do better. And we did do better. We built the first model, like I said, it was a regression model. And then Matt taught me the words machine learning, which I still can't say that I entirely understand, but I'm learning more and more. And this is the data from that paper from Critical Care Medicine, where we looked at this in over 121,000 University of Chicago patients. And we built a model that you can see predicts stage 2 and 3 AKI with AUCs in the high 8s. It does it regardless of where the patient is, whether they're in the ward or the ICU. It does it regardless of what their patient's baseline creatinine or admission creatinine was. It does it regardless of whether or not they're a surgical or a medical patient. And that's because there are lots of trends and things in the labs and vitals and other aspects of care that can actually predict who's going to develop AKI. In terms of what's in the model, or what was in that model, I should say, you can see it's a complicated thing. It's got 140 plus features in it, patient demographics, vital signs, changes in vital signs, laboratory values, changes in laboratory values. This model included things that we did to the patient, like giving them fluids or boluses, medications that they were exposed to, even if they had an LVAD. Back then, we were the coordinating site for the HeartMate 3 study, and we, at any point in time, had about 40 LVAD patients in the hospital, which is terrifying when I think about it. And so, not surprisingly, sorry cardiologists, LVADs are a risk factor for AKI. You can see though, we said, well, great, that's a very complicated model. We probably, if we're gonna move forward with this, need to shrink it down. And we did, we shrunk it down to about a 42 feature model. And we validated it in data from other hospitals, data from Loyola in Chicago, and then data from North Shore. And we demonstrated in those cohorts that the model, the sort of slightly smaller model, did just as well with great AUCs in predicting stage 2 and 3 AKI, great AUCs in predicting who's going to develop the need for dialysis across. You can see all 3 cohorts here. And so that from that perspective, it was great that we were able to validate it. We then set out trying to implement it and think about what are the sort of cutoffs that we want to use. And when we looked at the risk score here, you can see this is the, I don't want to say meaningless, but this is the risk score in the first column. You can see the number of patients. You can see that we can actually predict the development of stage 2 AKI. Depending on the cutoff, you want to use 24 to 38, so a day and a half earlier, with pretty great sensitivities and specificities. Not so great positive predictive values, which we'll talk about in a little bit, and great negative predictive values. So that from that perspective, it does a really good job of identifying folks. The issue is, from my perspective, the positive predictive value, whether it's 1 in 4, 1 in 3, or even in some of the newer numbers that we've got, as we'll talk later about some of the newer models that we're working on, you still wind up with trying to intervene on 1 or 2 patients or an extra patient or 2 who is probably not destined for the outcome that you want, or destined to develop stage 2 AKI. But to show you a little bit of a case, this is a woman who was on our inpatient heart failure service. On the left here, you can see her creatinines over time. Creatinines are totally normal. Baselines you can see between 0.7 and 0.9. When she's in the hospital, I'm sorry, you can see it here. I was pointing on the wrong screen. Baseline creatinine between 0.7 and 0.9, but when she's in the hospital being actively diuresed because she's volume overloaded, creatinines are 0.7 and 0.8 and rock solid stable. You can see that she's getting pretty good negative fluid balance, 2 to 3 liters a day. And all of that comes with changes in the labs that maybe we would all think to expect, whether that's hypokalemia, hypophosphatemia, a little bit of a rise in her bicarbonate because she has contraction alkalosis. Maybe her urine sodium is drifting up, things that probably don't get noticed when the serum sodium drifting up from 142 to 147. But when you look at what the risk score picks up, it's not just focused on the creatinine, it sees all of those things. It sees maybe a little bit increase in the tachycardia over time, a little bit of relative hypotension compared to where it was. And it actually triggered this woman for a study that we are doing where we're looking to enroll patients who are at high risk before they develop AKI to see if we can actually improve their outcomes, right? So to sort of summarize the biomarker piece of this, urinalysis and FST, I think, are both really useful tools. I don't think that the FINA should be used for much of anything, if I'm honest with you. I hate to burst people's bubble. I do think that there's a utility, like I said before, in measuring just the urine sodium at specific times, but that using readily available data, we should be able to identify folks who are going to develop AKI in the next 1 to 3 days. The issue is, what are we going to do about it, right? And so then this is a Twitter exchange with my friend Roger Rodby, who I know Laura knows. He co-directs the ASN board review course. He was earlier this year talking to folks about biomarkers and saying, hey, some of the biomarkers actually, maybe they work, but what good does it do if you know 24 hours in advance? To which I said, yeah, I actually think that there are lots of things that we can do 24 hours in advance that we're probably not doing. And over again, it's been shown that if you actually take care of people the way that maybe the Renal Fellow Note says to take care of people, maybe you can actually do better. And we've got data around that as well, right? So this is a table that has data from 2 Yale hospitals and data from U of C from a study that, again, Matt and I published with colleagues Dennis Moladina and Perry Wilson. What it looks at is, you can see here, we've got over 9,000 patients who have stage 2 AKI in these 3 hospitals, where Perry Wilson and Dennis are like me. They are AKI fanatics. And so that I have to believe at their hospital, along with others, people have tried to preach the idea of good AKI care. We looked at how many people had permissive hyperkalemia, how many people actually had a urinalysis done, renal ultrasound, how low did the maps go in these people who had established AKI? Did they have hyperglycemia? Yes, we haven't touched on that, but hyperglycemia over and over again is a risk factor for the progression of severe AKI. And I'm sure that your hospital has some protocol around preventing hyperglycemia. I've lived through the life cycles of all of the ICU, too tight, not, good sugar, bad sugar. But in the end, we still don't let people sit with blood sugars too high. And we know that keeping blood sugars under probably 130 or 140 in the setting of AKI leads to improved outcomes. But what you can see is that these 3 different hospitals, and while there are differences in terms of the individual hospitals, we all do pretty lousy jobs of taking care of patients who have AKI. We don't necessarily follow the guidelines around making sure that potassium doesn't come up. You can see you wind up with nearly 1/3 of patients with MAPs under 65. Don't get me wrong, there are plenty of people in my hospital who will never have a MAP of 65. They've driven to our hospital garage with their MAP of 55 because of their heart failure or their liver disease. Not every patient needs to have a MAP above 65, but I can assure you that probably more than 30% of them do. That there isn't that much heart failure, there isn't that much liver failure in this group. And so that we could do better. I think one of the other things we did in this paper is we looked at some of the, in quotes, nephrotoxic drugs, and then looked at the idea of how well or not well we do with caring for those patients. We looked at aminoglycosides, and you can demonstrate that, yeah, we don't use them that often in people who have stage 2 AKI. Across the board in all 3 hospitals, less than 2% of people were on them. And you could say, well, some people actually need their aminoglycosides, even in the setting of AKI. If I have gram-negative sepsis, you all have permission to give me an aminoglycoside. But what I want to see is that at least a day or 2 after getting a dose or 2, you're checking my levels. And we demonstrated in our own hospital that only about 3/4 of people had their level checked within 48 hours of having AKI and getting their gentamicin. Similarly, we demonstrated, apropos of what I talked about before, maybe with ortho and the patients not getting their creatinines checked, that whether you want to say 3 to 8% of patients with stage 2 AKI were getting NSAIDs after they had established AKI. There is not enough pericarditis in all the hospitals in the Midwest to warrant that much NSAID use in folks who have AKI. So we can do better. I certainly am not interested in getting into a debate about whether or not ACEs and ARBs are truly nephrotoxin. I don't think they are, but I think that it's a marker of poor care if your patient has AKI and you're continuing the patient has stage 2 AKI, a doubling of their creatinine, and you're continuing the patient on the ACE and the ARB. I guess I should have pointed out, this is Dennis and this is Harry. So we demonstrated in our own hospital and in other hospitals that AKI care is probably not what it should be. This is multi-center data from Europe looking at cardiac surgery patients, where they looked and did the exact same thing. So the idea here is to let you know I'm not the only person thinking about these things. This is data from Alex Zarbach and Lou Forney, where they demonstrated in about 200 cardiac surgery patients that, yeah, everyone does a great job of avoiding contrast, but all the other things that we know are bad for a kidney, not so much, right? We still get, depending on who you want to, whether you talk about the folks with AKI or the folks with, without AKI, 50% of them still getting something that's a nephrotoxin. Not everyone after cardiac surgery has optimization and hemodynamic monitoring, which seems crazy to me. If you've just had your heart operated on, you probably need to have pretty intense cardiac monitoring. People don't have consistent urine output monitoring. So with that said, there have been a handful of studies over the last few years that have looked at doing exactly this, taking folks who have established AKI and applying a care bundle to see whether or not it improves care. This is a paper that's about 3 years old, published by Nick Selby and his group from the UK, where they did a stepped wedge cluster randomized trial. You can see here over 24,000 episodes of AKI across different hospitals. They did a very intense AKI education program across those 5 hospitals to look to see whether or not they could impact morbidity and mortality. They did detections and alerts, with the idea being that all of this was done when patients already had established AKI. So they had to have bumped their creatinine or had prolonged urine output decreases. They didn't just talk to doctors about it, they did talk to nurses. You can see that the core elements of a care bundle included simple things like treating sepsis if it was present. I know that's crazy, right? Treat the sepsis if it's there, but also assessing the volume status, making sure that you're looking at the urine, making sure that you're looking at the patient's medications. And they did it in a variety of capacities. Like I said, they didn't just lecture the medicine residents or the hospitalists or the APNs. They went out and talked to the nurses. It was a major undertaking, and that they demonstrated quite nicely that they were able to identify more patients who had AKI. They were able to provide better AKI care. And that from my perspective, this is sort of what's useful to hear, is that they were able to implement care so that people got their fluid balance and their fluid status checked. They did more urinalyses. They didn't wind up overwhelming radiology with more renal ultrasounds, because not every patient with AKI requires a renal ultrasound if you're thoughtful about it, right? They reviewed patients' medications. I don't know if I'll meet later today, the Caudy police from the University of Wisconsin. I am intimately familiar with the Caudy police at the University of Chicago, because every study that I want to do that involves collecting urine or requires a Foley needs that extra bit of scrutiny. If you take good care of patients with AKI, you're not putting in more Foleys, because not every patient with AKI needs a Foley. If you have AKI and you have non-oliguric, why do you need to collect 1,200 cc's of urine in a Foley? You can let that person pee freely. And I think most importantly for the nephrologists out there, it led to more, but not statistically more, renal consults. So you're not overwhelming the system, and you're demonstrating shorter length of stays, more AKI identification, and better care for your patients. I think it's important to acknowledge that not every study has demonstrated the same improved outcomes. This is data from Perry Wilson and his group at Yale, where they did an automated alert. This is what the automated alert looked like. Your patient's most recent creatinine is 0.93. The lowest one that they had was 0.3. This is what the highest one is. They're at risk. Here's access to the order set to take care of AKI, right? As opposed to maybe a broader educational program that you saw from the UK. And they demonstrated a couple of things. Most importantly, and we'll get to it on the next slide, they didn't demonstrate any sort of improvement around AKI metrics, but they demonstrated that if you tell your colleagues that a patient has AKI and you give them an order set to click that says, hey, here's more fluid, they'll give more fluid. They'll give more fluid as a bolus, they'll give more fluid as a drip, and they won't necessarily be as thoughtful about it. In fairness, you can look at this slide, really no difference in terms of nephrotoxin exposures, which I think is great. No difference, no significant difference in terms of things like the cost of care. There was, as I said, no difference in AKI progression or need for dialysis or death. But they did notice this trend, which I think is somewhat alarming. They did it across multiple hospitals in the Yale system. Some were teaching, some were non-teaching. And they saw this signal for increased death in the alert group in the non-teaching hospital, that if you go back and look, It's hospitals where there's not someone looking at someone 24 hours a day. You've given them access to care, and they've demonstrated in that table more access to fluids. They also had more access to diuretics. And the discussion highlights the idea that, well, maybe if you're given a list of things to check off and you're not actually going and looking at your patient, you can actually do harm to the patient, is how I read this. That you can, if you give people fluid and or diuretics without actually thinking about what's going on, that's going to be bad for someone who has AKI. We already talked about the idea that volume overload in the setting of AKI is bad, and they demonstrated that patients with in that alert system wound up getting nearly 2 liters more than patients who didn't get the alert, right? So that it's not all wine and roses. This is another study from the UK, from Lou Forney and his group, where they did a 2-hospital system where they did a similar idea. They had a risk score to identify patients who either had stage 1 AKI or maybe at risk for it. They did a before and after, and in a control and non-control hospital. So one hospital had the intervention, the other hospital didn't have the intervention. They demonstrated that using the bundle led to decreased inpatient mortality, decreased overall mortality, but not necessarily any changes in AKI. And I tell you, I'll take that as a win. If you're providing AKI care and more people are leaving the hospital alive, that's great, especially when you say compared to the control hospital, you still were able to demonstrate an improvement in patient mortality. And so that good care around AKI isn't just focused on the kidney, it's focused around the rest of the patient. The last trial that demonstrated this sort of benefit, this is the Pravaki trial, which was a single center trial. So unlike the other ones we talked about, which were all multi-center, but this is one that paired biomarkers and a care bundle in patients after cardiac surgery. They measured TIM2, IGF, BP7, and they used this care bundle, which I don't think really has too many crazy ideas. Avoid the nephrotoxins, hold the ACE and ARB, monitor serum creatinine, avoid hyperglycemia like we talked about before, no contrast, and then hemodynamic monitoring, recognizing that these are cardiac surgery patients. The hemodynamic monitoring was pretty simple, at least from my perspective, nothing crazy here. If your stroke volume variation wasn't an 11, we gave you fluids. If your cardiac index, remember, these are post-cardiac surgery patients, so they all have index and output that are readily available and read. If you're not at 3, hey, do something to make that better. I think a cardiac index of 3 is not too crazy of a goal, and a MAP goal of 65. Again, not too crazy of a goal, using whether inotropes or pressors. And if you achieve those goals, you leave them alone. And they demonstrated the same thing by applying that bundle with those hemodynamic monitoring. They actually were able to decrease the rate of all AKI, decrease the rate of severe AKI, and improve patient outcomes. And that was in patients who only had elevated biomarkers rather than waiting for serum creatinine or urine output changes. So when we talk about clinical care, I think it's important that just because you write no nephrotoxins doesn't mean that I see the nephrologist nodding. That makes me feel good, right? That's the same thing at our house. You have to be specific. Say, stop the Toradol, right? If that's what the agent is. Or can we think about switching the Toradol if you don't want to be as dramatic as I am? I think that over and over again in the last 5-10 minutes, I've shown you that when you apply AKI guidelines, you actually provide better care. Don't necessarily always improve the AKI. I'm also a big believer that some AKI is just going to happen. The people that you have here at Wisconsin are like the people we have in Chicago. If someone's coming for their 3rd cardiac surgery, that's probably a bad sign. You're coming for salvage chemotherapy, it's salvage chemotherapy. You're going to break some eggs. Not all AKI is unavoidable, but if you do a good job, your patient is more likely to leave the hospital alive, and you can be thoughtful about it. I think I'm going to close by talking about this idea that we just have serum creatinine and urine output. All of you, I would imagine, or most of you have thought about interpreting a blood gas where you get multiple pieces of information. I've shown you over the last 40 to 50 minutes, we've got multiple biomarkers that we can use, that you can use to triangulate what the heck is going on with your patient, right? Whether it is an electronic medical record score, I'm not talking about removing serum creatinine or urine output. Those are not going anywhere. We can still use those as valuable tools. Talking about whether you can use the urinalysis or some of the other biomarkers, furosemide stress test and fluid overload as how much reserve or how much the kidney can compensate, and begin to think about a multimodal assessment of where your patient's at in terms of what their kidney can and cannot do. And that's part of, I think, why I'm here and what we're trying to do. With Matt, we've got a bunch of different funding opportunities. We have an R01 that I'll get to in a second. We have an R21 that is a clinical trial that uses that risk score that I showed you to randomize patients to nephrology consult versus no nephrology consult. As a career advice, don't get your first R grant or R21 6 months before a pandemic starts. It really screws with clinical trials, but we're back up and running. We've got about a quarter of the patients enrolled, and hopefully in the next month or so, we're going to have our first interim analysis to demonstrate whether it was effective or not. But more importantly, we've got an improved risk score that we're working on. And then in a multi-center fashion with Brad and Tripti, we're going to collect samples from patients here who are at high risk from the risk score to see if we can pair some of those biomarkers with patients who are at high risk from the electronic medical record, as well as look at the care that those patients are receiving to see in certain subpopulations, do some care guidelines matter more than others? Does your avoiding nephrotoxins mean improved outcomes more so in the ICU than on the ward? Does making your MAP targets or your hyperglycemia impact those with liver disease different than those with cancer-based AKI? And so you'll be hearing more, and maybe some of you out there will be seeing your patients enrolled in some of these studies over the next couple of months to years. I already sort of talked about all of this in terms of conclusions. I want to make sure there's time for questions. I also want to acknowledge that all the work that I've shown you that we've done is not done in a vacuum. It takes multiple people to do clinical research these days, and I've created multiple consortiums, and I wouldn't be here without all the people who've helped prop me up, most of all my family, but folks at the University of Chicago, folks who were at the University of Chicago who are now here, and the folks here who are working on the e-stop stuff, which is the electronic medical record stuff, biomarker folks, furosemide stress test folks, and then importantly, my colleagues back at the University of Chicago who are doing research consults for free to see patients in the name of trying to improve care for AKI. I'm going to stop there.
Thank you so much, Dr. Koyner, for the wonderful talk. A lot of important teaching points in that, and a lot of things for us to think about here at university. So do we have?
I don't know that, Joe. I don't know that. That's not.
All right, sorry about that. So I was just thanking Dr. Koyner for giving us that great talk and everything we have to think about care of our renal patients. Any questions in the audience? Dr. Schnapp?
Thanks for a great talk, and I'm just delighted that you do not propose FINA. I hate FINA. Two questions. One, early in your talk, you talked about not moving the needle in the prognosis of AKI. Have we moved the needle in terms of the development of AKI in critically ill patients, for example? So you mentioned the ARDSNet study. One of the things the ARDSNet study did show was that lung protective ventilation prevents the development of other organ failure. So have we seen a decrease in incidence of AKI?
So we've seen slow but not dramatic decreases in it, right? I think that I wish that it was more so like the COVID story, if I'm honest with you, where in the beginning, at least for us, we were seeing a lot of AKI, and now very infrequently. We're still seeing, if you sort of take all ARDS folks, you're still seeing certainly 10 to 20% down from 30 and 40%, but there's still AKI in general, whether MICU, SICU, trauma, is still associated with the worst outcomes, right? It's one of the reasons I became a nephrologist. I kept finding all the sickest patients also had AKI, and we've made headway in some groups, but not all of them, right? And I think the easy example to actually cite where they still consistently get AKI and severe AKI at 10% is cardiac surgery. Just for going and being on the cardiopulmonary bypass, all the maneuvers, all the drugs that we've tried and failed, all the different techniques, you still wind up with, depending on the surgery you're going for, 5 to 15% of folks who go on a cardiopulmonary bypass machine wind up with doubling of AKI. I'm willing to throw out the stage 1 AKIs, which some people think are less important, but that even for ARDS and for cardiac surgery, you're still looking at 30% of folks with small bumps in their creatinine, which correlate with adverse outcomes. So we could do better.
And then my next question, you mentioned doing fluid assessment when you're triggered. What is your thoughts on the best method for fluid assessment, particularly in the critically ill population?
Yeah, so, right. Well, that's a great question. I think that as I round on our ICU service, there is not a patient that I see that, and regardless of the unit that they're on, where someone isn't feeding me a piece of information that they weren't 20 years ago around POCUS and what their IVC looks like, or even what their renal vasculature looks like. I think that for me, there's not going to be one piece of information that does it. I think that I still, as I said, I rely on things like the urine sodium, but I rely on pulse pressure variation, which my monitor can now show me pretty regularly or pretty easily, and you can check it yourself with POCUS, with the ins and outs, with what the urine is telling me as the way that I assess the patient's volume. There isn't just one thing that I use. I think the thing that I've become a little bit more reliant on than the past is the POCUS exam, and I'm comfortable saying it's not something I grew up doing, and it's something that I'm slowly learning to do myself. I don't know how the nephrology folks here, if they've got a program in it, but it's something that we're trying to implement. And if I'm honest, we're piggybacking off of the pulmonary critical care folks on that slide where I thanked people for sure, people like Jesse Hall and folks from pulmonary critical care at U of C, where they've sort of led the way along with folks like Michael Koyner from anesthesia, where we have gotten them to teach our fellows how to do some of that point of care ultrasound stuff so that they can assess. I would argue even more important in someone who's already on a machine when we're pulling fluid from them, when we know to sort of back off and we're not inducing relative hypotension with dialysis is a piece that's almost to me more important than the pre-AKI assessment, because pre-AKI, there's so many people competing for what's best for the patient, but once someone's already progressed, we want to do as little harm as possible with the dialysis machine, and there's a lot of harm you can do with a dialysis machine from pulling people, and that's where personally I find POCUS even more useful. As day 3 on CRRT, what does that IVC look like after we've pulled for 2 or 3 days?
Thank you. So we've got 2 online questions. One is, do you have any advice for transplant providers in preventing AKI in their transplant patients besides reducing tacrolimus?
Well, you're talking, I guess I don't. If we're talking about kidney transplants, outpatient AKI, I think or AKI in general in those folks, I think it's true for all, not just transplant patients, making sure you've got sick day protocols for your patients. So that they understand, because we beat into our transplant patients, especially, you got to take your meds. Same thing with heart failure patients. And people will have intercurrent illnesses and diarrhea and say, I kept taking my tacrolimus, but I also kept taking my ACE inhibitor and my SGLT2. And those are medicines that by definition already sort of expose the kidney to less volume than maybe the kidney wants. So making sure that you have those pieces in place. I know every time I pick up a transplant patient when they're 6 to 12 months out from our transplant clinic, and this is true for both kidney transplants, but because I see AKI patients, I see a lot of other solid organ transplant patients. I give them our sick day protocol, which is if you're having nausea, vomiting, diarrhea for a day, keep doing what you're doing. If that one day becomes 2 days, you need to call us, and then based on the meds that they're taking, if they are on RAS agents, the calcineurin, SGLT2s or ARNIs or other things, hey, you got to stop those for a day until you are able to make sure that you're keeping stuff inside of you or keeping stuff down.
Great. And so then our other online question was, you had talked a lot about cardiac index and predicting AKI, but there may be some studies thinking more about right atrial pressure and JVP. What do you think about those markers?
So I think that the right atrial pressure, you have to know what's going on with your patient, right? If your patient has an elevated right atrial pressure because they've got pulmonary hypertension and vascular congestion, that's very different than then they've got it from a massive submassive PE that they just had. So you have to use all the information in the context of what's going on with your patient. We've certainly moved, at least in our hospital, we've moved away from being solely reliant on CVP, which is, I think, something that we did for many years. Yes, not every patient has a cardiac index or a cardiac output, but at least the patients that I see, 30 to 40% of them are still in our combined cardiac surgery, cardiac unit, and they have that information. And as a nephrologist, you have to be comfortable figuring out how to interpret that.
I know it's past 9, but I'll try to be as brief as possible. Just a comment on the FINA. I mean, I agree with a lot of what we said. We recently did a dive into this here in our program. I'm one of the nephrology fellows though, and I agree. The very first studies about FINA were kind of like very small studies. They included a couple patients. Actually, the very first one that Dr. Espinal published in JAMA, the sample size was like 17 patients total, which is very small amount. And then a lot of studies followed up on this, which also had a lot low sample size. We presented like last month the last meta-analysis that was done about FINA that really went into all studies that evaluated FINA in the past 50 years. I honestly, like practically speaking, I know that having new good biomarkers is great, but I don't like to really abandon FINA, because practically speaking, I know from a nephrology standpoint, it's very important not to rely on just a urine sodium and regardless of everything, I take decisions based on just like a urine sodium and a FINA. But in the non-nephrology world, I think we should really still use it because it gives a lot of reassurance. Because as I mentioned in the meta-analysis, it still showed a lot of high sensitivity even in people with diuretics, people on CKDers. I know it's like great. It really showed very high sensitivity and specificity when patients are not on diuretics and non-CKDers, but still it's pretty sensitive in other groups. What I'm trying to say is maybe in the non-nephrology world, practically speaking, it might give a lot of reassurance and avoid unnecessary consults and make things more like practical.
I hear what you're saying. I guess I would say no one should be using FINA or urine sodium in isolation. I understand that, yes, it can reassure you maybe a little falsely that your patient is dry, but just as I said, the assessment of a patient with AKI, whether they've got an ICU full of equipment, or they're in the ER, or they're in your outpatient and they went for labs before they showed up in clinic, it's still going to be multimodal. You still have to say, does this person, what does their volume status look like? Do I think that they're perfusing their kidneys? What can I do to alter that? I hear you. I actually agree, and I don't think I highlighted it, but in folks who are getting diuretics, I totally send a urine sodium, because if that urine sodium is low, it's telling me that the diuretics that someone is giving them, the kidney is trying to override that system, right? And sometimes it is because the patient is still congested, and they're so congested to the point that the diuretics aren't getting there. But sometimes it's, more often than not in my world, it's they've already been over diuresed for 3 or 4 days, and now the creatinine is bumped a little bit, and someone has called nephrology to figure out why that is, so that there's utility for it. But I'm not in favor of giving people sort of the false sense of security with a biomarker that maybe works 55% of the time. I'm getting the wrap up sign from the audience. I gotta go.
Oh, yes, I use FINA never.